For an individual developing agoraphobia, the physical world begins to collapse inward. Environments that were once mundane, a grocery store, a sidewalk, a bus, gradually become inaccessible. Clinically, this is defined as a marked, intense fear of specific spatial situations that persists for 6 months or longer. Diagnosis requires fear in at least 2 of 5 areas: public transportation, open spaces, enclosed spaces, crowds, or being outside alone. This is driven by a perceived inability to escape if panic occurs. As escape routes disappear, the patient's world shrinks. This is an active anxiety disorder. The body produces real physical panic symptoms when the person tries to leave their safe spaces, which distinguishes it from shyness or a simple preference for staying indoors. Agoraphobia effectively turns the external environment into a zone of perceived physical danger. This creates a unique paradox. The very anxiety that makes someone need professional help is often what prevents them from reaching the clinic. A standard appointment requires the patient to navigate heavy traffic, stand in tight crowds, and wait with strangers. This journey maps directly onto the condition's triggers. The bus ride and enclosed waiting room are the exact environments the patient avoids. Because agoraphobia often co-occurs with panic disorder, this required commute can leave the patient completely housebound. In this traditional model, the healthcare system unintentionally requires the patient to endure their most feared situations before the treatment can even begin. To break this cycle, clinicians use cognitive behavioral therapy, or CBT. The central component of this recovery is a process called in vivo exposure. As seen in this progression model, exposure involves taking gradual, systematically controlled steps into uncomfortable environments to build tolerance, starting from a baseline of safety. Licensed clinicians may also incorporate SSRIs. This chart shows how the medication stabilizes the physiological baseline, making initial steps manageable. However, in vivo exposure is difficult to initiate if a patient is already in a state of high panic, just from the act of traveling to the therapist's office. For this therapy to be effective, the patient must be at a stable baseline of psychological safety when the session begins. Telehealth provides a logistical solution to this specific medical barrier. Video-based therapy removes the commute and the waiting room from the clinical equation. Therapy begins in the one place the patient currently feels secure, such as a specific chair in their living room or their own bedroom. Starting from this established safety allows the therapist to lead the patient through the first steps of exposure at a pace the patient can actually tolerate. This remote delivery makes the gold standard treatment accessible to those whose condition would otherwise keep them isolated. The goal of the therapy is to systematically push the patient's boundaries back outward, reclaiming the spaces that have been lost to anxiety. Executing this requires a clinical infrastructure that can provide exposure-informed care remotely. Coping and healing counseling operates this type of telehealth practice, providing the specific CBT framework needed for agoraphobia. They maintain a team of over 15 licensed therapists, including clinical social workers, professional counselors, and marriage and family therapists. Because the practice is 100% telehealth, they provide HIPAA-compliant coverage across all 159 Georgia counties, bypassing the need for patients to travel to a major city for specialized care. Even when the geographic barriers are removed, the financial requirements of specialized therapy often remain a final obstacle. To address this, the practice is in-network with major insurance providers like Aetna, Cigna, and Humana. Notably, for those on Medicaid, the copay is $0. By removing the physical, geographic, and financial barriers to traditional care, this model lets recovery begin in the only place it can, the home.